In the just published EURETINA guidelines for the management of diabetic macular edema, laser is still mentioned as having an important role. The EURETINA guidelines recognize the mechanism behind laser therapy in closing leaking microaneurysms and small blood vessels. The EURETINA guidelines also recognizes the early studies that shows that laser is more beneficial than sham therapy. However, according to the guidelines, the treatment with laser is far inferior to the treatment with pharmacological agents such as anti-VEGF agents and steroids, and therefore should usually not be exercised as primary therapy. The EURETINA guidelines do recommend laser therapy for remote areas of leaking microaneurysms and blood vessels that are not in the center and that can still be amenable to laser therapy without causing damage. So in patients that have central macular edema, basically pharmacological therapy as first line is the way to go. However, there are situations in which there is something like a circinate maculopathy, namely an area of lipids surrounding microaneurysms, and even just remote microaneurysms. These can be still treated as laser as primary therapy. In addition, in patients that get pharmacological therapy, be it anti-VEGFs or steroids or one and then the other, if they have persistent edema, which they have at a high percentage of cases, then many times we do a fluorescein angiography, and if we identify what we call treatable lesions, namely microaneurysms leaking small blood vessels, then we're still treating them with laser as the best therapy. Even though theoretically a combination therapy would be beneficial, many studies showed that it's not actually giving any advantage to add the laser up front to anti-VEGF therapy. Moreover, in sub-analysis of protocol I results according to baseline visual acuity criteria, if the visual acuity was not optimal, was less than 20/50, then doing laser up front even caused worse visual acuity results. So I don't think that nowadays doing laser and anti-VEGF therapy together up front is a viable option. But we do need to consider adding laser therapy if the response to anti-VEGF therapy or to steroids is not optimal. Using laser in a patient that has central edema and does not have remote leaking microaneurysms, in my opinion, would be contraindicated as first line. It would be indicated only in resistant cases or when the edema is mild, remote, and there are leaking microaneurysms far from the foveal center.